Afternoon. The Committee on General Government Operation and Appropriation now called to order. Today is Monday, February 26th. The time now is 2:03. In compliance with the Open Government Law, the notices for this public hearing were posted on the GovGuam Public Notice Portal, KGTF TV Channel 21, Docomo Channels 117, and disseminated via email to all senators and all main media broadcasting outlets on Monday, February 19th, and Thursday, February 22nd. This oversight hearing is called on the Guam Memorial Hospital Authority. The committee will discuss an overview of GMHA appropriations for fiscal year 2024 from all fund sources, the allocation of appropriation, encumbered appropriation, capital improvement, and other projects funding sources, other matters pertinent to their fiscal status. At this time, I ask the members of the Guam Memorial Hospital Authority to please rise and be placed under oath by the Sergeant Arm.
In writing, be the truth, the whole truth, and nothing but the truth. Okay, Mr. Chair, under oath. You may proceed. Thank you.
Thank you, Sergeant Arms. The general rules for this oversight hearing. Please provide my legislative staff with any document for distribution and for photocopying. Please, panel members are asked to remain in the room for questions or for additional testimony as may be desired by members of the committee. Question and testimony shall be confined to the substance or nature of the agenda. Personal inference as to the character or motive of any senator or any individual testifying is not permitted. Any violation of this general rule of conduct will result in removal from the oversight hearing. Proper form and decorum shall be practiced by all present in the public hearing room for these proceedings. Individuals who fail to maintain proper form and decorum will be restricted from participating and will be removed from the room. When you speak, please make sure that the microphone is on and that you speak into the microphone. Please state your name and your title for the record. Once you've introduced yourself, once you don't need to keep on saying who you are. Okay, just one time to start. I'd like to thank my colleague, Speaker Therese Serlai, for being here this afternoon. And I'd like to acknowledge the panel that are present. We have Lillian Posadas, the administrator, William Kando, we have Zadi, I don't know pronounce your last name. I don't want to. Tugadi? Oh, even just as easy as Lillian. Okay. And we got Dr. Duenas, we got Jordan Pollen. Anyway, we got Yuka, the CFO, so we're going to know where the money's at. And we got Rodolin Geralda, right? Geraldo. Correct? Geraldo. Okay. All right. With that, I'd like to first greet you all good afternoon to my colleagues and the panel from GMH, and especially the people of Guam. We've called this oversight hearing to review the financial conditions of Guam Memorial Hospital Authority with the objective to ensure fiduciary responsibilities are being upheld. Through FY 2024 budget law, GMH has been appropriated $30 million for fiscal year 2024. $8 million coming from the general fund and $21 million coming from the pharmaceutical fund, along with additional federal assistance allocated from American Rescue Plan. If I provide the wrong information, please, when your turn to speak, please correct it, okay? Allocated from the rescue plan, you have $18 million for operation. You have $8 million for nurses' pay, I think. Is it $8 million or 8,000? Okay, I'm reading information I've gotten from OB, okay, or the information, okay? So feel free to correct it as we go along in reference to the ARP, okay? 40,000 for infant audiological equipment. Maybe the amount may be wrong, but correct it. Provide us the information on it, okay? So we can bring clarity. Okay, we got $6 million for vendor payments. Are we correct on that one so far? $6 million for vendor payments? $30 million total. Oh, okay. That's the other appropriation. Okay. Okay, and then the legislature will provide emergency appropriations of $30 million to cover outstanding vendor payment and to perform necessary repairs, correct? We're good? We're good on that. Okay. However, it is apparent that GMHA still continues to struggle to maintain general operation and maintenance with the funds provided. During this hearing, we will review and discuss the following topics, but not limited to. First one, vendor accounts payable, ARP funding, current and planned capital improvements, information technology, electronic health records, finance or fiscal department related matters focusing on what is being done to improve collections. And I look forward to this discussion and to identify potential measures we can look into now that may help address critical needs of the hospital to ensure we continue to support our hospital and meet the healthcare demands of our people. What we're hearing today could lead to the information I'm going to need during the budget, okay? Or what we need to do before we get to that budget, if there's anything we can do. Okay, I'd like to also recognize Senator Barnett has joined us this afternoon. Zeus Mossi, and with that, I'd ask if, Lillian, you can provide us an overview. I know you have slides, right? Okay, and if you want, we can do the slides now, and then we can ask the questions as we go along. Okay?
May I just do a brief opening statement?
Yes,
Senator?
Please.
Okay. Thank you very much. Buenas, Senator Joseph Agustin, Chairman of the Committee on General Government Operations, Appropriations and Housing, Speaker Teresa Lahi, and Senator Chris Barnett. My name is Lillian Perez-Posadas. I am the hospital administrator, and on behalf of the Board of Trustees, executives and management, medical staff, employees, and the patients we service, we extend our gratitude for giving us this opportunity to update you and the members of this legislative committee on the hospital's current fiscal year 2024. With me, as you have already introduced, you want me to go ahead and introduce the people? Okay, sure. To my left is our CFO, Ms. Yuka Hechanova. To her left is the acting social administrator of medical services, that's Dr. Vincent Duenas. We're going to try and tie him down so he doesn't retire, but we wish him well. We respect his decision. To my right is Mr. William Kando, Assistant Administrator of Operations. To his right is Ms. Rodalyn Gerardo, who is our Deputy Assistant of Operations. And then to her right is Mr. Zaudi Tagadi, who is now our Acting Associate Administrator of Operations. And behind me, we have Mr. Jordan Pauloon. Not all of our executive leadership are physically here, but I'd like to recognize them as they contribute immensely their insightful thinking to the effectiveness and efficiency of the hospital's operations. Ms. Danielle Manglonia is the Administrator of Quality, Patient Safety, and Regular Compliance. Dr. Larry Lizama, he is our SNF Clinical and Medical Management Director. Ms. Pauline Lizama, she oversees the Department of Corrections on-site clinics as the Hospital Nursing Supervisor. Ms. Bel Rada, she is the Assistant Administrator of Professional Support Services. Ms. Christine Taquero, Assistant Administrator of Nursing Services, and Ms. Lizelle, the Deputy Assistant of Nursing Services. Did I miss anybody? Before I hand over our presentation to our CFO, Ms. Yuka Hechanova, I'd like to take this time to clarify what seems to have been a miscommunication on our part when we submitted our fiscal year 2024 budget request. What we requested to cover our projected operating expenses, that is how we're going to run and operate the hospital, was $193.8 million. And that included the additional request, which was a shortfall when we saw it, of $42.2 million. However, I know that the Speaker Talahi increased the budget request from $19.9 million from the pharmaceutical funds to $21.7 million, and from the general fund from 3.5 to 8.5. So the total legislative appropriation was $30.2 million. While we extremely are thankful for the additional pharmaceutical and general fund appropriations of $6.8 million, it was still short of the total $42.2 million additional funds we requested to run the hospital. Hospitals across the U.S. with similar bed capacity as GMH typically operate with an annual budget of $180 million to $200 million. So on that note, and given the focus of this oversight hearing is on our fiscal year 2024 budget status and our CIP, I'll hand over now the presentation to Ms. Yuka Hechanova to begin the financial data. Thank you.
Okay, Ms. Lillian, you wanted to pose a simple question?
Yeah, you said you requested $42 million over what the governor had
Correct.
sent?
This is what we submitted in our budget request. This is the, summary of it.
Yeah.
And we
All
did
right.
indicate 42.2 million as far as our request for the fiscal year
Yeah,
2024.
above the governor's.
Yes,
Okay,
ma'am.
thank you.
Okay, please proceed.
Oh, there we go. Okay. Next slide, please. And Ms. Lillian just gave her opening remarks, but our mission statement is on this slide. Next slide, please. And the agenda for today, which the good senator has already discussed. So I'll start with the next slide on the FY 2024 appropriations. So our FY 2024 budget appropriation was 30.2 million, and the balances are all there. We were also appropriated from this Public Law 3743, $30 million to pay vendor payables, and to date, the balance there is 5 million. We have another 5 million from Public Law 36-107 for specialty physicians. That balance is still at 5 million. There are some vendor payments that were paid with the 30 million, about 1.5 million that will need to be reclassified to the Public Law 36-107 appropriation. So that's being worked out with DOA right now. So with our budget appropriation of 30.2 million, that comes out to about 2.5 million a month for our monthly allotment. Next slide, please. For January 2024, this is our condensed income statement showing our total operating revenue compared to January of 2023 last year has greatly improved. We have overcome a lot of the hurdles that we faced during the go live of our EHR and our network shutdown and a lot of the things that we faced in 2023. So operating revenue is improving, and we're actually tracking for operating revenue for the year about 132 million. However, our operating expenses are continuing to grow, and we always have a loss from operations. So for example, in January 2024, our loss from operations is 15.2 million. And that is where our appropriations come in to offset that loss. And for this month, for January 2024, the transfers from GovGuam is 34.5 million, but 24.3 million of that is actually the vendor payments that they made on our behalf that we are recognizing as non-operating revenue. So the actual appropriations allotments that we received was actually 10.1 million. So technically, we still have a loss in our net position. So for the appropriations, looking at how we're tracking for January, our operating revenues are tracking for about 132 million for the year. Our expenses are actually tracking at about 192 million a year, which is very close to what we estimated in our budget. So our estimated loss from operations right now are 60 million, and then our subsidy from the government of Guam of 30.2 million. So we're still expecting a shortfall of about $30 million this year.
You know, I'm just trying to track what you're saying, and I don't see that in your slides at all. You know, as you mentioned, 32 million, 130, 192.
Oh, I'm sorry.
And we're trying to see, like, okay, where are you at? I'm trying to see that number. Do you have that somewhere?
It's in my notes, but I will very happily offer that to you later.
Okay,
Is that
please,
okay?
Please do.
But the gist of it is we're still tracking about $30 million short this year, shortfall.
Okay, when you mentioned you got 32, why are you short? Is it because of the non-paying customers?
Not necessarily. Our expenses have been growing a lot, and our revenues are just not enough to cover those expenses.
But when you say I'll give you a good example. If you have a patient that comes in and is covered by insurance, are you getting reimbursed from the insurance when they're supposed to follow whatever rate you're supposed to charge? Was there an agreement that if you come in and you put in a room, it's $100 a day. Insurance, you know that, you pay it when the patient's
Yes.
there. Is there an issue there?
Not with the insurance, it's pretty much with the amount that we get reimbursed from Medicare and Medicaid because it does not, it's capped. It's pretty much capped, so we don't get all of the charges that we give them. Plus, we have a significant population of self-pay patients that we are slowly trying to...
But when you mention the Medicaid and the Medicare, how is it capped if that's the rate they're supposed to pay nationwide? I mean, I'm trying to understand, is the federal government telling you will charge less and you take a loss? Is that what you're telling us? Is that what's happening nationwide? Because if that's the case, then we need to be in a position to find a way to help offset your losses, because then you're never going to get out of the hole.
Yes, this has to do with the rebasing that we've been talking about. Whenever we come to legislature, we do express our desire to rebase our Medicare discharge rate. So Medicare, right now we're based on FY 2014 costs, and that is the cost that they will give to us, but nothing more than that. So our cost compared to FY 2014 are almost double what it was in FY 2014, but Medicare is only reimbursing us based on 2014 costs.
And what has been the communication with the federal folks to say that you need to raise the rates? That's 10 years ago right now. I know they follow the trend. I mean, they're not that far behind, but where do you all stand on convincing them that they need to raise it? Because it doesn't make sense. It's like finding out, does GRMC get reimbursed for everything? Does NRMC, because it's a military installation, do they get reimbursed by their federal counterparts that say, hey, we're going to give you because of Medicare? I'm just curious, because it doesn't make sense that the only public hospital we got is just, you're never going to get out of the hole, no matter what you do. And it doesn't make sense, at least in areas that they can do something to prevent you from getting too deep. That's what I'm concerned about. Has there been any communication with those folks to say, hey, 10 years old, can we update it? Can we get at least halfway there? That's what I'm concerned about.
There have been some meetings and discussions, but because they pay us on a different program, it's called the TEFRA.
Well, then how can we change the program so that we can be on the right program to get the proper reimbursement?
It's at the congressional level.
Congressional level? Okay, then at least we're saying this out loud, and Delegate Moylan, take note, por favor, and get it fixed. It's at its level. It's not ours.
Yeah.
But we still need to figure out a way how to help you, because you're no different in a predicament like DOE's in. Okay, and I just want to make sure that we all come to terms that there's certain things the legislature can do, but we can't just keep saying, we'll give you money, and it just keeps going down that hole. It just doesn't make sense. Maybe you just got to change the way the program is being done so that it fixes itself and just doesn't dig you deeper in the hole. But go ahead and continue.
Yes, so we've been meeting with DOA to help us with that process. So there is a complicated process to actually do the rebasing. So it was last done in 2016. The former CFO, Benita Menglone, is the one who started that path, getting the consultant in, working with the consultant to get all of the documentation ready so it can go to CMS, and then eventually it was approved. So now that we are 10 years down the line, we even have to probably do this every 5 years, because the costs are just never going to be the same as they were on the base year. It's always going to go up. And especially with the pandemic, it has gone up tremendously, and there's no going back. It's never going to go back down, especially with the costs for our pharmaceuticals have been so expensive. The price to pay for personnel, for clinical staff, it has really gone up. The travel nurses we're using so much of right now that we didn't use as many before. So there's a lot of different moving parts right now as opposed to the 10 years ago. So this is really something that we are very serious about, approaching the consultant to please help us with this, because we're losing so much.
But everything you're saying is nothing, it doesn't require you to be a scientist to figure this out. The trend has been happening. Mm-hmm. What I'm concerned is that if your federal counterparts are not responding, then the question is we should be asking is, How do we fix it at our level? Who do we send the bill to? Okay? Because you got to be able to send it to somebody. You can't just keep holding on to it and says, well, we're going to reduce this, we're going to stop this, we're not going to fix the mold, we're not going to fix the electrical, we're not going to do anything because we need to fix this. There's got to be a point where Necesito un jale handbrake and says, hey, stop.
Yes.
Medicare, if you're not going to respond, because you know when you mention it's a hard process or it's a difficult or it's whatever. A year, if it was a year ago, I can understand that. But when it's already 8 or 10 years, it shouldn't have been hard. And Dr. Duane is going to agree with me because in the military, if you already know the problem, then find a solution, not an excuse to keep going. You got to find a solution so you can move forward. But just go ahead and continue. Thank you.
Thank you. So can we move to the next slide, please? Cash receipts. So this is an overview of the losses that I had talked about. So the upper part of the slide shows that as of January 2024, our loss from operations is 15.2. In 2023, it was 80.6. And in FY 2022, 60.8, and 2021, 69.4. So these are all post-pandemic periods where we're pretty much doubling what our losses were before. Our losses before were around 30 million. And then cash receipts are disclosed on the bottom there. So as of January 2024, we've collected $52.2 million from all sources, and then 145.5 in FY 2023, and 177.9 in 2022, and 159.8 in 2021. So in FY 2023, we did have a significant decrease from the 2 prior years. Again, this was really from a lot of the issues that we experienced with our IT side, and it impacted billing and collections tremendously. So with the $30 million appropriation that we did receive to pay the vendors, it really made up the difference for the decrease in the collections for those years. Next slide, please. And then speaking of billing and collections, as of last Friday, we've billed almost under $25 million. So we're averaging about $25 million a month going out in bills to all payers. Our expected collections is $54.5 million, but our actual collections are $45.1. There is a column on the
And why is that? Why is there a $9 million difference?
well, almost $5 million of that is the Medicaid clawback. So
Okay.
we've been paying back DOA for our Medicaid loan that we took out last year. So they are recouping that. So part of that is that. And then the rest is just, so in essence, we've really collected almost $50 million or even more than $50 million, which is very close to what our expected collections were. But we do have to pay this back to DOA.
Okay. No, well, we'll figure out a way where you don't have to pay it back because you're not going anywhere. Thank you.
No,
Go
we're
ahead and
not.
continue.
Next slide, please.
I think your slide is different than what we have.
We're looking at it looks like this.
Yes.
But look at October. So October is higher than November, right? In our slide. What about yours? Can you go back to the previous slide?
That one.
See?
It doesn't look the same as what we have in front of us. As you all can see.
Oh. I'm sorry. Yeah, my slide looks like that one. So I'm really not sure what happened.
Okay. Well, maybe we can. Did you? You know, I just don't want us to keep going and then we're going to find slides that may have some problems. Why don't we go ahead and pause for a few minutes and you
fix
can
it?
fix it? But at the same time, I'd like to recognize my colleagues that have joined us. We have Senator Sabina Perez and Senator Frank Blas and Senator Roy Canata that joined us. Also with Senator Barnett. And we can go ahead and take a 5-minute so we can double check the slides and we keep the flow moving. Thank you. All right, we're back from a short recess, an update of the spreadsheet. Ms. Yuko, you're on. Let's try that one more time. Let's go back to this one here. We'll make sure that we all understand this part and then
Yes.
continue on.
Okay, so that is, there we go. Yeah, that's the one. That's the correct one. I don't know where I left off. So this is the summary of the billing and the expected collections and our actual collections. And then on the last column, it's the amount that is being recouped by our Medicaid reimbursements. So that's almost $5 million.
All right.
Okay, so next slide, please. So our accounts payable as of February 23 is 16.1 million. And I apologize, that first line that says owed to DOA, on the total column, it should say 4692452. The number did not carry over to the total column.
So you're saying move the 90 over to,
No, it's just the total column. It's just missing the 4.69 for the owed to DOA.
oh, okay.
So in total, it's 16.1 million, and then we owe DOA the 4.7 that they paid on our behalf to the travel nurses. So that brings it down to 11.4 million. We have another about 1.7 million of payments that DOA is still pending to make to the vendors. So that brings the total accounts payable to about $9.7 million.
So you're saying they got 11 million still to pay and then it'll wipe out that 9 million?
We still have to pay $9 million to vendors.
Okay.
And that's spread out over current 30, 60, and 90 days aging. Next slide, please. And then our accounts receivable is divided. The top half is our 3 M's, which is Medicare, Medicaid, and MIP, our self-pay and government accounts. And the total, I had to divide those up into those that are over 360 days and then under 360 days. And then we also have a column for in-house. These are patients that are still in the hospital. And we do something called cycle billing, so we do bill periodically for those accounts. And the total on these two are 91.6 million in AR for Medicare and MIP and Medicaid, and then 244 million for self-pay and government. The bulk of that is in the self-pay bucket. Under insurance, our local insurance total AR is 26.6 million. Of which we estimate 13.8 to be collectible. I just want to finish. I just want to finish. Do you want me to? Oh, we'll wait.
You want to make sure that it's on the screen that everybody else can see it.
Oh, it just
Because
is
I look down, I look up and like, up at it.
Are these Medicare and Medicaid accounts receivable, the Medicare ones, the actual receivables, or that inflated amount that they will never pay?
So the first column says estimated collectible, and so it's 21.1 million that we expect to collect from the 91.6, based on historic payment habits. That's how we've been.
And the rest of it is something you can't get
We can't get, yeah.
because of that program
Yes.
that the
Yes,
United
sir.
States Congress needs to fix, right?
Yes.
Okay, I'm going to keep repeating that. That's Delegate Mola needs to fix this, not us.
Yes. I
Okay,
agree.
thank you.
And so on our self-pay bucket, the self-pay is 235 million on the self-pay, but we only expect to collect about 5.5 million. And we have been, we reinstituted the garnishment program, and we are also going to start procuring the services of a collection agency, so we can divide those payables into what we can send to garnishment and then what we can send to collection agency. So we're working on the mechanics of that right now.
You got self-pay estimated as 5 million, but you got 235 that's sitting out there that you can collect?
Yes, because most of that is actually sitting in the over 360 days, and so the collectability of anything that old is very low. It's possible, but it's very low. So in our financial statements, we actually have an allowance for the entire amount that's over 360 days.
And then you got one with the government, and you're only estimating 1.3, and the government owes 9?
Yes.
What is that? That's not the Medicaid, because it's already up.
No,
it's up
this
above.
is, part of that is DOC. So when DOC sends their the inmates to our hospital,
But we appropriate to DOC to, or make sure
but
that.
this is old. It's like very, very old accounts that are still on our books that we will probably have to write off. Yeah, they're
Or
very
you
old.
need to request the legislature to pay it so it be done.
Or we can
Need to
also
wash-
do
need
that.
to wash it off.
How old? What is this?
We have accounts on our accounts.
The DOC, because we've gone over this for years already, and you guys always said we were caught up with DOC. So what is this?
There's very old accounts, very old.
Okay, well, if you can give us a full report exactly how old, so that we'll know.
Okay.
Okay,
can
just
do
give us
that.
a report on that one, because you say it's old, it could be actually just last month, but it's really not yesterday. You know, I'm just saying this, you know, but you gotta give us a date when we're looking at, when supposedly it went over the cliff and everybody forgot somebody went over the cliff. Let's get it back up, okay? Moving along.
And so for the bottom part on the insurance, the total receivable for the insurance is 26.6 million, and we expect to collect 13.8.
Why the big, what, that's 50%. What
So
happened there?
we still have some patients that are in-house, so that's the in-house. Less than 90 days is where we estimate we can collect. Over 90 days, we just have a complete allowance for that. Those are probably most likely denials that we are still resolving, so they still may be collectible depending on the outcome of the denial and the appeals that we have. And then some may be pending still on our coding bucket that needs documentation before we can continue coding and billing it. And then we have some that will just not be collectible because we probably lost the appeal for the denial, and it will be for write-off because it's not collectible. And also the age.
When you say, you know, because if I get insurance, I have to pay this every payday. It doesn't matter. The insurance got my money. They're supposed to pay the hospital for the, I was a patient. When you say you go to appeal, why do you need appeal? You got a bill, pay it, whoever you are. I'm trying to understand. You know, the people of Guam needs to understand, because if they become a patient and they got insurance and it's not working, they need to reconsider who's insuring them. So they're covered,
Yeah.
and they don't have to worry about it when they're going to check out. It's like, Mr. Duenas, I'm sorry, but you do have a bill that your insurance is not paying. And they'll look at, wait, what are you talking about? That's something that needs to be resolved, because you have from 11 to 17, from 13 to 26. Yeah, there's something missing here. And that's why I brought up the issue about the insurance. And when you say it's owed, nothing should be owed, because payment was received by the patient for their insurance. And I'm going to safely assume the hospital is working with the insurance to make sure that whatever's being charged, they understand to pay it. Not to make the excuse on why they don't want to pay it. It doesn't make sense, you know. A patient pays for insurance so that he don't have to haunt him later. So I just wanted to make sure that was clear.
Yeah,
Again,
we meet with the local insurance at least once a month to go over any of these outstanding claims. So my staff have been meeting with them more regularly now. And if there are denials still where we bill the insurance, and sometimes they will not pay the whole bill.
Well, what are the reasons for denials? Can you please
There could be
give us some
a
examples?
non-covered benefit. And then
Like what, drugs or
Yes.
staying in a room?
sometimes if you come in and you are on drugs, they will not cover it. It will
No,
not be
you
covered.
mean if you're under the influence, what you're saying?
Yes.
Or the diagnosis that's written by the doctor. medical
What was
diagnosis, drug use, drug abuse, insurance won't pay it.
I think a lot of the people of Guam need to understand that. It's like if you're driving the street and you get in an accident and you're DWI, insurance automatically breaks off. The people of Guam needs to know this, that if somebody hits you and they're under the influence of alcohol, their insurance will not cover the damage you receive. Okay, and maybe that needs to be, I don't know, somehow promoted so the people of Guam understand. If you're under the influence of drugs that are not prescribed, you will not be covered by your insurance, and it'll be done with.
Yes.
Okay, go ahead and continue, please. Oh, wait.
Are these accounts receivable amounts they were billed or they were not billed? Because you said some of these are pending coding. So are these actual invoices?
Yes, so whenever there's something happening, the date of service, the charges for the date of service, then it will drop into our AR. So they may not have been billed already. We're now billing as of January, I think it's mid-January right now for the local insurance, but we are still, I think 6 to 8 months behind on Medicare and Medicaid for billing. But they've all been coded. We've had a task force put together. The coding is down to almost nothing right now. So a lot of those coded claims now have to go out for billing. And so now the billing is ramping up to get those claims out the door.
Is there a timetable? If you don't send the bill to them, they can deny you.
Yes.
Look quick. And what is the timetable? 6 months?
90 days for the local insurance. So those are always the priority because of the time frame. We have 1 year for Medicaid and Medicare.
I'm just concerned because when you say you're 8 months behind on some of them, it's loss.
For the local insurance, yes, we only have 3 months. So that's why we're prioritizing which ones need to go
Is any
out.
of your billing for accounts receivable is already a loss because you didn't send them the bill?
Yes, that's a possibility, yes.
Okay, please advise us of the total amount. Because the next question I'll ask you later on is, do you have the people to do it? And if you don't, then put for vote, explain it, but just continue on with your presentation. Thank you.
Okay, I think we can move to the next slide, which is new services. Do I talk about this one? So these are the new services we have instituted and the total number of patients. Our newest one is for gastroenterology services and procedures, which is on the bottom. We hired Dr. Paul Munya-Agan in July 2023. And so he started seeing patients, I believe, in September 2023. And so we have been ramping up that service since then. Next slide, please.
This one is the transitional care site issue that we're challenged with, particularly because of the social cases. And these are cases, or these are individuals who've been in the hospital and have no place to go because they don't have a home or a family support. So they're in the hospital. Some of them are more than 1 year. And for those that, total of them are at the acute site, we have 12 of those individuals who just have no place to go, so we call them social cases. And then at the skilled nursing facility, we have 12 individuals out of the 20 residents that are there. And the total cost for serving these individuals who can't go home at the hospital is $9.7 million since the time that they've been admitted. All of this have been accumulating. We do send out the bills because some of them are on Medicaid and some of them are on Medicare, but we don't get the full reimbursement. So this is the total cost that has accrued from the time that they were admitted since 2021. Some of them were.
Okay, when you mentioned that they got nowhere to go.
Correct.
GMH is not in the business of holding people back, but I don't want you to kick somebody out either because
We don't
they still
either.
require medical care.
Correct.
is there any other way that this can be handled other than just you doing it? I mean, is there a federal grant out there that can pick up the burden? Because 14.5 million is a lot of money.
Yes, it is.
And there's got to be it's no different as it's like when there's grants out there to help fund a program. Has anybody researched to find out if there is a program that can take over this so that it's not funded by GMH? Because it doesn't make sense.
Right. And there is a program under the Medicaid, but not here in Guam because of our Guam state plan. It is available in some of the places in the United States where family members are incentivized and are paid
But
to take
Lillian,
care.
when you say because of our state plan, in other words, we cause our own problem.
Well, we need to amend our state plan to have that so we can
but who creates the state plan? Us, no?
Right.
So as long as you self-inflicted, okay, and let's not blame nobody else. We caused that problem because if the plan needs to be changed, it's evolving, huh? Change it as you need to change it. Don't make the excuse that, and I'm not blaming you, but we shouldn't be, I hate to say that because of our state plan, we need to make the amendment to the state plan so that we don't have this issue.
Right.
$14.5 million is a lot of money.
It is.
That you can be using to pay off your vendors faster.
Right.
Okay,
So
anyway.
that is one option. The other option is that we are meeting with public health. GMH is meeting with public health, behavioral health, and DICIT to see where we can establish a transitional care facility. So that's in the works, the details of it, but we don't have it right now.
Well, we'll get with public health and ask them to speed it up.
Yes.
Okay,
I
thank you.
am. Thank you. So next slide, I'm going to have
Good afternoon, Senators. Name is William Kando, Assistant Administrator of Operations. Again, this slide, recently completed projects in calendar year 2023. We have shared this slide with you previously, but it still deserves repeating some of them, especially as it pertains to upgrades to the roof, and we're working on the envelope, but we completed the roof A, B, D, and E wings, the repairs and coating of the roof. But we still have the envelope that's in the design phase, and we're going to be pushing out, working with the designer. We hope to be pushing out the construction phases for the envelope repairs in the coming months, because we're going to do it in phases. We're looking at different floors, so we're looking at March, April, and May to complete those designs. We're working very, very feverishly on that one.
But when you say on rooftop repair and roof coating and mechanical upgrades, you stated A, B, D, and E. Mm-hmm. You're at a certain phase of it, right?
Those have actually been completed. The rooftop.
But the rooftop
envelope
is repaired.
The envelope is coming down the building, the exterior sides of the building.
But that section says rooftop repair. That's completed, correct?
Yes,
or
sir.
No?
Yes,
okay.
sir.
How about the roof coating? Is that done?
Yes, but we still have some lower portions of the roof that we haven't done yet.
I'm just going down the line based on this screen, okay? I'm not doing anything else,
Yes.
okay? I'm not reinventing what you got on the slide. Mechanical upgrades, is that done?
On those wings of the rooftops.
Of course, we're only talking about A, B, D, and E wings. Remember, I'm not going offline, okay?
Yes.
I just want to make sure. So in other words, you can check mark that section is completed.
Yes.
Now you may have other added things you need to do to ensure that the repairs are worthy, correct?
Yes, we still have the smaller portions of lower rooftops like C-wing.
I mean, then that's what you say.
There's
but
also a portion where we have our solar farm that was damaged by Typhoon Marwa, and we're still looking at that. We haven't completed that repair yet.
But the rooftop is repaired, the roof coating and mechanical upgrades are done, correct?
Yes, on A, B, D, and E wings.
Okay, so I'm going to check mark that section that is completed.
Yes.
Anything else that has to do with it, it's not rooftop repair. I'm just trying to go down the line on your slides. Okay? I'm not doing anything else.
Yes.
Okay. Because I don't want you to add a bill on something that you check mark, it's repaired.
Yes, sir.
Okay, go ahead, continue now.
We continue to do quarterly maintenance on our main panel and sub-panels with our collaborative partnership with GPA. And you can see what we've completed from all of the quarters last year. And then we recently completed January. And then we're set up for our next maintenance pass in April of this year. The alternate care site, this is the skilled nursing facility, FEMA public assistance grant. We completed that medical equipment package so that the SNF is ready as an alternate care
Please
site.
advise, as you say it's completed, we check mark, because it's not check mark name that's completed, okay, on the slides?
Yes, it says recently completed in calendar year 2023.
When you put a box next to it, William, it means it's not. When I look at the other part that got a check mark, it means it is. The last time I checked, it's like going to take a test, A, B, C, D. If you don't mark anything, you didn't answer.
Yes, everything on this slide is recently completed in calendar year 2023.
So then we don't need to pay attention to any of the empty box on the left then. Okay. So everything's completed, good. Okay, go ahead and continue.
We have the GMH air handling units that were completed, 23 out of 71 total. So that one is not totally completed. We're just letting you know out of that total, what is completed out of that 71.
When the air conditioning unit is completed, that means the molds are gone.
Yes, when we complete all of the installation of the air handling units, we will feel much cooler throughout the entire hospital.
No, the molds. You know, there are molds in the hospital.
Yes,
If you put a new unit and the molds are still there, all you're doing is forcing the circulation of the bad air. Am I correct? I mean, if you got mold in a room, you turn on a fan, what you did was you just forced the circulation of the mold, the bad air. I'm just curious. Air conditioning is done. Is the hospital cleared of mold? Remember, it's all over the newspaper. There's mold not cleared. I'm just concerned.
and we have a slide that we're gonna focus on that later on.
Okay.
Yes,
But just remember, I've already asked that question, so
yes.
thank you.
And so, and you can see the split and portable AC units that we've installed prior to and immediately after Typhoon Mawa. 91 split units and 40 portable ACs in varying sizes that we've used to help mitigate the situation. And then the GMH main chillers, these are the GMH main chiller, existing main chillers
Okay.
that we repaired, did repairs to this
Mr.
past.
Cando, before you get there, back to the GMH air handling units. So this whole report here is almost exactly what you reported in January when we had our oversight hearing, except for where you're saying 23 of 71 AHUs procured and installed to date. In January, you said 25 of 64. There were more, and there were only 64 total.
That's correct. That was a error on our part.
Okay.
That we miscalculated the total number. It should have been 71.
And then the split and portable ACs, exactly the same number as in January.
That's correct.
So no changes really on these completed projects?
In calendar year 2023.
No, on the list that you gave us since January, it's the same.
Should be the same.
All right.
And then you can see the repairs that we made to the main chillers, the existing main chillers, both repairs by replacing the variable frequency drive power modules and also chemical and tube brush cleaning. That really enabled GMHA to stabilize the environment of care at the hospital, you know, relative to the ventilation system. Next slide. And so on the next slide, these are ongoing CIPs in CY 2024. We have additional HVAC system upgrades that are, you know, underway in the procurement process. For example, the RFQs to replace the main chillers. We're expecting quotations submitted February 29th of this month. So we hope we are successful in that endeavor. We're trying to also send out packages 4, 5, and 6 to remove and replace additional air handling units.
In January, you said the RFQs, you said those were going to be IFBs. Did you solicit with an IFB and this is the response?
No, we're switching from
You
an
switched,
IFB to
yeah.
an RFQ
Why'd you do that?
because we can and it's quicker.
All right. So why did you report IFBs last time?
We were considering, we packaged it as an RFB. IFB. So now we've transitioned to RFQs, as advised by the legislature to expedite where we can.
And
using the
so
procurement process.
you're expecting these responses, the quotes to actually be submitted February 29?
That's right.
That's the progress. Okay, thanks.
We're still trying to package successfully construction phases for air handling units for the ED, ICU, OR, OB ward. These are the full-on AHU replacements as opposed to split units. You can see just below that, we're looking at some of the same units to install split units, which is really an intermediate fix. The more permanent fix is, of course, the air handling units. For example, you've heard, I know you've heard a lot of talk about the OB ward split units. So we had installed the split units, DeSony had installed the split units, and so what was pending was the installation of the power source for those split units, which we've recently awarded. We put out an RFQ.
Sorry,
And,
quick question, RFQs, are you using this emergency selection, or how are you basing your RFQs on?
It's an emergency procurement process, yes.
And so you're using the federal level? Or what's the cost of these air conditions?
The split units,
Yeah.
the split units came in at, under the federal ceiling, it came in at 200,000. The federal ceiling is 250,000 for a small purchase.
Okay. Yeah, I just have concerns about the rate of expenditures within RFQ. Did
Yes.
you properly
We're also
make the
using
determination?
the hospital administrator's emergency health powers under the procurement rules and regs.
Sorry, can you go back and talk about how you switched from IFBs to RFQs? What was the purpose, the reason?
So that we're not going through the formal process, but we're still going through the competitive process.
How many respondents did you have?
They haven't responded yet for the chillers. That's expected on February 29th.
Did you make any kind of comparisons to see what, because I'm thinking often the scale of purchasing can help bring down the cost. And so are you treating each individual purchase as an RFQ?
It's an RFP package that allows all potential bidders to submit their quotations.
So, but you have your RFQs versus, I mean, those are different source selections, RFP versus an RFQ.
No, it's a similar selection process. You're still looking for the lowest responsible quoter.
No, it's not the same. RFP and RFQ are different.
IFB and RFQ.
I thought you said RFP.
IFB and versus RFQ.
Okay, all right. All right, you can continue. I'll just,
But are they being packaged as one all together or separately? Like they can give you a quote for one part or one piece?
So the RFQ, we have one RFQ for the 450-ton chillers and cooling towers, and a separate RFQ for the 265-ton backup chiller and air-cooled condensing units.
Okay, continue then.
Another one that is ongoing is our liquid oxygen tanks and enclosure expansion and replacement of the tanks. We expect to be complete with that, commission those tanks in the next week or two. Medical vacuum quadruplex system replacement, that's ongoing. It's been awarded. Angio suite and hemodynamic machines replacement, that's been awarded, and anticipated completion is in April of this year. Other FF&E packages that we're trying to procure relative to the OR towers, anesthesia machines and scopes, and various other medical equipment. Maternal and child health renovation, we're transitioning from the design concept phase to the design phase for the nursery and ICU upgrade. And we have Typhoon Wawa recovery phases ongoing. Next slide.
Okay, right before we go there, I just want to go back real quick to Yuko on the insurance. Is the process for insurance claim payment less or more complicated under the GovGuam self-insurance program versus the old insurance program? Which is it more? It's pretty much the same.
It's the same. We just submit the claim and then we get paid.
The reason why I bring this up because of the denials now you're getting. If it's self-insured, then it should be better.
Yes.
Okay. And our claims by, okay. Okay, that's what I wanted to know. So in other words, self-insured could be a better program today, as long as you're not beyond 60 or 6 months or
90
whatever.
days, yes.
90 days. Okay. Continue on, William.
We're looking for the next slide. Yes, thank you. These are CIPs that are in the pipeline. This is the electronic health record update where we continue to work with the Governor's Office and the Office of Technology. We continue to work internally with the executive leadership and the Board of Trustees relative to restructuring the Information Technology and Communications Department. And we're working with the EHR vendors to address systems interface and support issues. Some of these additional planned IT network and systems infrastructure upgrades are actually in process. We've already awarded the end computing devices IFB, which was 175 mini computers. That's going to be a big improvement to our IT network. We are yet to RFP the active domain management system, but that's already with materials management to let out an RFP for that. We've already awarded replacement of our servers, quantity 10, so we anticipate those coming in the month of, hopefully in the month of March. We're looking at transitioning from the current RCM software to an RCM cloud, and then we're developing an RFP to go after a new electronic health record. So that's still an RFP in the development phase.
You're doing an RFP for a new?
That's correct.
What's wrong with the current one? Is that bad? I mean, is that old?
We launched it in October, but in launching it, we've discovered that it really wasn't built for an acute care hospital landscape. It was
Okay.
more for a behavioral health, and so the clinicians, the doctors and the nurses are still struggling with it. And so we recognize, and therefore, it is in the best interest that
Okay.
we procure a new
I
EHR.
understand. Okay, thank you.
We still have a Z-Wing demolition 1 Bravo to do. As you know, we've demolished probably about two-thirds of the building. We still have the second floor of that Z-Wing to demolish, and then we would be in a position to retrofit the ground floor of that building for fiscal services. We still are working on repairs to GMH boilers and water heaters, and also a major removal and replacement of at least one of these boilers as soon as possible. We're coming out of a design phase for that. We still want to relocate and replace the main panel and the sub-panels, replace the sub-panels as well. We want to replace one of our 1.6 megawatt generators, and we're in the process of replacing our CCTV surveillance system and access control system. You'll hear more about some of these projects as Rodolin Gerardo presents the 20 million on the next slide.
Good afternoon, Senators. Rodolin Gerardo, Deputy Assistant Administrator of Operations. So this is the $20 million ARPA funding, and so I'm sure you're interested to find out where we're at on this. Pretty much, we have not drawn down any of the $20 million. I'm sure that's one of your questions, and the reason for that is because many of these projects, as Mr. Kando had already explained, we're still either procuring them or we've just recently awarded them, and since doing so, we're not in a position yet to draw down any of the funds on some of these projects. So, for example, yes.
You mentioned you got RFPs out there until you're awarded, then you draw it down? You can't draw it and put it in the bank? And, just want to make sure that you're ready to pay.
Yeah, it's federal funding, ARPA, so it's still with DOA.
Oh, so you
Yes.
just need DOA to give you the
Correct.
money, so
Yes.
you can have it in the bank, so when you need to pay it, you're ready to pay it. And then YUCO don't have to say, where am I
Yes.
gonna juggle money from? Okay, I just wanted to make that very
Yes.
clear. Okay.
So, yes. So that's why for these, Mr. Byrne, we're working with DOA, Mr. Byrne, and so, of course, he'll also tell you that none of the $20 million have been drawn down, so we just want to make that clear. It's still with the Department of Administration. So going down the line, I'm not going to go through each one of these, but pretty much Mr. Kando explained many of these projects already. But pretty much we have the chillers, of course, that's under procurement. The envelope, we're still in the design phase. And so Mr. Kando already mentioned that the liquid oxygen enclosure tanks expansion project, we're almost done with that. And so once we're done with that project, we're actually working with the vendor now on trying to recommission that or commission that project. So once that's done, we can actually then get invoice, and at that point, we can draw down the funds. That's for that $144,000 there. For the Z-Wing demolition, Mr. Kando just explained that. The parking lot expansion, we're currently trying to go through the solicitation process for that. The NICU expansion, Mr. Kando already explained. The AHU we talked about, as well as on the SNF HVAC chilled water lines, we're working on the solicitation for that as well. On the...
A very simple one.
Yes.
You identify a parking lot expansion, $1 million. What are you doing? You're building 2, 3 floors of parking lot or what? I'm just curious.
No.
And the reason why, because you don't have a lot of property up there.
Correct.
And I don't care how anybody will look at it. You got to go up. I know you're not going to go down. So what is the 1 million? I'm just trying to picture $1 million for
Right.
people to park.
So the estimated $1 million, that's of course just an estimated cost until we go out and procure. But that is intended for, the middle section of the parking.
Yeah, the island
The
there.
island.
Yeah.
So it's to remove that and create more parking stalls.
And you're estimated $1 million?
That as well as the portion.
That, as well as the portion, the 2/3 of the building that we brought down for the Z-Wing, that we turned into temporary parking, we have designs in hand to then convert that.
$1 million, William? Come on.
It's for both of those, yes.
Everybody, if you got an island, just ask Public Works, come out there, bulldozer, clear it, move it away. Now get somebody to pave it and be done with it and mark it. I'm just trying to picture $1 million for a parking lot.
Yes.
It's just something I don't know, maybe I don't do the math often, but I do. So I just want to make sure, but you can move along.
Yes.
I'm just looking at all your estimates. And
Yes.
that's why I asked the question about DOA. Maybe Lillian or you go ask for the money. Hold in your account. So when you need to pay it, you don't say, can you issue the check? Issue the check, pay it, and be done with it. That's my opinion, okay? I don't know how that's going to work with them down there, but 20 million, if this 20 million earmarked for you, you should have it in your hands. Because I don't know what's going to happen tomorrow. They're going to say, well, we're not going to give you the 20. And Yuko's probably going to be, he's right, take the money where you can, because I don't know if it's going to be there tomorrow. But you're going to need it. All these projects, we're going to be asking, where's the update? Okay, go ahead and continue.
Okay.
Your $1 million parking lot, go ahead.
Yes. Of course, on the HVAC system improvements, we talked a lot about those already. Moving down to the IT network systems infrastructure. So, of course, the servers, again, that project has already been awarded. So once we get the items in, we can go ahead and get invoiced, and then we can go ahead and draw down. And then we are also looking to get some new ups, 30 kVA UPSs, as well as a 15 kVA UPS. This is for our IT network. And moving on, we're also trying to get, as part of our 20 million ARPA, medical equipment such as the hemodialysis unit, CT scanner tube, acute care ventilators, BiPAP machines, so on and so forth. That's what we have so far.
Okay. Madam Speaker.
Was this list reviewed by the Fiscal Review Committee, the one that was created by executive order by the governor to prioritize use of funds by GMH?
We have shared, but it's been revised, and so our next meeting with the DOA for that fiscal review committee is March 15. So we will give them the updated version that we have today.
Okay, because this was also pretty much the same list that was reported in January, so none of these have begun. It doesn't look like they're really priority.
No, ma'am. Just to clarify, several of these since the January have since been awarded. And there are other projects that unfortunately, because some of them are still in design, it takes a little bit longer. And of course, as we all know with the procurement process, it does take a while when we have to go and solicit. We have to develop the specifications, put it out on either a bid or even to request for quotes. It's been a challenge for GMH.
All right, so you're saying these are active regardless of the fiscal review committee's approval or assessment of it?
Oh, just to clarify, ma'am, so a lot of them are, have been reviewed, and you are correct, majority of them are the same, but we did make a few changes to this since then.
Yeah, all the medical equipment's new. You
Yes,
took out
ma'am.
the EHR 1.5 million and replaced it with all this different medical equipment.
Yes, ma'am. And the reason for that is, as we all know and has been previously reported by our representatives from the hospital, an EHR system for 1.5 million is not going to be enough. And so it did not seem reasonable to keep it in here, you know, trying to compete with, you know, just a $20 million pool.
Okay, and so on the last slide, you said the RFP for the new EHR is being prepared, going to go out, but we already know it's going to cost more.
Yes.
Yeah, this is what one of the questions at the last hearing. Is it really reasonable that you're going to get a new EHR system for, where are you going to get that money then?
So,
Because you've scrapped the last one, we weren't able to bill, now we don't have a plan?
We're still
What are you
using-
certifying the funds with the RFP?
We're
with?
still using the current EHR, but it is a struggle for the
No,
clinicians.
for the RFP that you're issuing, how are you going to pay that?
we're not issuing yet.
We will
And-
need, we're looking for to certify the entire 5-year period, not just the first year, the entire amount.
Right? So this RFP's not real yet.
No,
You need to find the money first.
That's correct.
And you have no idea where that's going to come from at this point. Right? If
Correct.
it's not going to come from the ARP, it can't come out of the
it is a funding source that has not been identified yet,
All
that's
right,
correct.
thanks.
What's the cost?
We're researching that, we're trying to determine, at least,
What's the
give
going
ourselves.
rate? What's the going rate then? If you
For a
don't know,
5-year period, it could be 20 to all the way on up to 60 million. It really depends on who the most qualified offer is and how we negotiate that price,
That was one of the factors why you went with the system that you went with, because another system for 60 million was just out of our reach. And so now that this is why it seems backwards to me that you made a decision that we're not going to continue with the system, yet we have no idea how we're going to fund a new system. That doesn't make sense, especially if this fiscal review committee's not coming up with where are we going to find that money. Otherwise, you should plan to continue with your EHR. I mean, it doesn't make sense.
We have to. We have no choice. We have to continue using it. But, again, the struggles, we hear the struggles of the clinicians. And so from that's why we decided, okay, we will then go out and do an RFP for a new system. Thank you.
okay, you got the last page, the mode?
Good afternoon. I'm Saldi Tugari.
Move the mic. There you go.
I just got detailed today. I'm also, I guess, I'm going to be wearing a lot of hats in addition to what I already have, but that's fine. It's all for GMH. So I'm going to be discussing the GMH mold approach of GMH. Again, what we have here, as presented earlier by William and Rodelyn, part of those CIP, part of all those infrastructure projects are in alignment with this spore mold project that we would like to address. So we have already all the reports. I think those were all been shared. We have shared that with the board, and again, we have separate ones for GMH and SNF. Our implementation plans of corrective action is in progress for both facilities. Removal and placement of ceiling tiles, that's ongoing. As we go ahead and see what needs to be replaced, we go ahead and replace them as we see. Again, part of the CIP project, which is very basic and vital to the mold remediation project, would be the HVAC upgrade, HVAC system upgrade, because that is the first and foremost recommendation of our IHP, the consultant that we hired. Of course, we also have the replacement of AHUs again, installation of the split units, deployment of AC with dehumidifiers, and pretty soon portable dehumidifiers will be coming in soon. We have, again, we're in progress. We're replacing the chillers and associated components. The next one we have here is the hospital upgrade that comes hand in hand with the HVAC system upgrade. So we cannot just proceed with just the HVAC. We need to proceed with both. So as you can see, we are taking strides in the application, and depending on the prioritization of the projects that we get approved and get the bids out and get awarded. For the envelope, we just had a meeting, and so we're looking at the design of the entire facility to be completed by this year. And then, of course, what would follow is the implementation of those plans. What we're doing right now is we're phasing them as we go on. So basically, we're looking at about 4 phases to complete the design. So as each phase of design is completed, we'll go out with the RFQ. And again, of course, with the money availability as far as funding is concerned. Pretty much all this covers, again, the envelope, as you know, would be the exterior surface of the facility, which involves the windows, doors, and associated ceiling of what we have there. Replacement of typhoon shutters. Mind you, the typhoon shutters that we have were designed in 1997, a UBC code. We are now 2024, so that's how far back we are. Before, it's always only designed at 155 miles per hour. Right now, we're looking at 200 miles per hour, so that's the difference right there. Of course, it includes also the wall hardening of our interior courtyards, where we always have this vortex effect inside that pushes in and out of our courtyards, thereby really taking out our long and wide shutters. And then, of course, this comes along with the replacement of the mechanical systems that goes along the surface of the rooftop and the envelope itself. Thank you.
You know, that's why I asked earlier about all the air conditioning you're replacing, about the mold. And then it's repeated here. HVAC system upgrade. Of the 23 of 71, which one got mold? Everything other than the 23?
I'm sorry, can you repeat your question?
You know, when you mentioned earlier about the air conditioning split units being replaced, of the number of air conditions that are completed, the ones that are not completed are the ones that got the mold problem, right? Or no?
Those where we have not replaced the air handling units yet, you're going to have warm pockets that we're not meeting our temperature and our humidity ranges. So that's where you have your risk for mold.
No, I don't want to know about what the risk is. I want to know what exists. The mold exists. It's ready. It's all over the newspaper, okay? Now you can, unless you're going to tell me you don't got a mold problem at GMH. Are you going to say that?
Until we replace the...
No. I asked the question, do you have a mold problem at GMH?
We have mold on our floors.
Then you just say yes
We have
first.
mold on our walls. We are cleaning them daily.
William, just follow, okay? Don't, trust me, you're not gonna dazzle me with a lot, okay? I've been through that down the road. All I'm asking, you got a mold problem. What are you doing to fix it? If it's in an area that requires air conditioning upgrade, was that part of the 23 units that were upgraded and you still had a mold there? No. Error. Clean it up, then put the air conditioning in so you're not circulating this stuff, okay? The next one is that I asked the question, out of the 23 out of 71, I'm going to find that page, but I know she's looking at me, she knows what I'm talking about. You identified 23 of 71 air handling units procured, and installed. So out of 23 of 71 makes what, 48? No?
Yes.
Hey, good math, no? 48 units not done. Is that where have the mold problem? That's what I need to know.
Very likely, that's where where we have a mold situation. But,
Okay.
but we still made a huge improvement after Mawa when we stabilized our chillers, because our existing air handling units that have not been replaced yet are still working.
When was the mold revealed that it existed there? And what measures were taken to clean it? Because if you had mold in your house, I know you're going to go after it. You're not going to, let me wait for the next payday. No, I'm going to go after that. I'm going to get whatever I need to buy at Home Depot, and I'm going to clean it. I need to know, the people want to know, what are the steps being taken? You find a mold in a room, clean it up, secure the room, get it done, then reoccupy the room. Okay, that's pretty much common to do.
Yes.
I'm curious what is GMH doing? Because we need to fix it, because if a doctor's going to go in a room and there's mold, he's going to be like, hold on, I need my patient out of here.
So basically, Senator, we're implementing our plans of corrective action that we've developed based on the IHP reports, the mold assessment reports from the industrial hygienist. We developed 2 plans of corrective action, one for GMH, immediate, intermediate, and long-term plan, and one for the skilled nursing facility.
I want to know what's going on at GMH. We'll talk about the SNF, okay? Where are we at in GMH? Like I said, it's all over the news. There's mold. I mean, some doctors are talking about it so much that I'm wondering if they got mold in their brain. But, I leave that alone. I'm curious about the wealth and well-being of our patients.
Yes.
And anybody that is not a patient could be a patient because they walked into a hazmat area. And I'm just curious, because when the doctors are there, they could be walking into a room not knowing that they could end up getting sick. They're not going to take care of the patient because they're getting sick because somebody didn't clean the room. Somebody didn't wash off the mold, repaint. Do what needs to be done. I understand you got steps. But I would say, never mind the steps, start running and getting it done.
No, we're not, they're not just steps, we're actually in the implementation of those
then
steps.
explain that.
Okay.
There you go, then explain that, please.
Yeah, they are
Because the
cleaning.
people are listening, what are you doing? So we can end this.
We're doing the cleaning every day, replacing the ceiling tiles, and our infection control nurse and employee health, they're monitoring and doing the surveillance on a regular basis. So,
Okay.
So even, if I may add, just at the very basic, yes. So, of course, one of the very first steps is removing the moisture, right? So, mopping the floors every day, anything that's visible with the mold that we can remove on the surface, then that is being done by our environmental service team, as well as our FM. Again, removal of the tiles that, appear to be moldy and so on. Those things are being done. We have deployed the dehumidifiers. Actually, we've installed some of the AC units that do have the dehumidifiers, and we are in the process of procuring standalone dehumidifiers to put them in, strategically put them in the places that have been identified that, seem to have a higher mold count and so on. So those steps are being taken as we speak as part of our mold mediation.
Okay, because,
mitigation process.
and the reason why I bring it up, it's all over the news.
Yes.
They talk about it like there's nothing going on. They talk about it like no, they're not doing anything at GMHA. And I want you all to say what you're doing.
Yes.
Because if you don't speak out, I'm telling you.
Yep. So, even the deployment of portable BUV HEPA filtration systems. So you talked about earlier the concern with, the air quality and so on. So, the filtration systems are being deployed in certain areas based on what has been identified in the report. As well as the team have been, the FM team have been monitoring the humidity level. So based on the report, the recommendation does say that the humidity should be within a certain range, and majority of them, per the report, the areas that were tested initially were higher, but since putting in our immediate and intermediate actions, the humidity levels in many of those areas have since gone down. So we are seeing an improvement, and the FM team are continuing to monitor that as well. So we are taking steps to correct the situation.
Okay, I just needed to be stated,
Yes.
okay?
Thank you.
That's the biggest thing. Going back just a little bit further back, then I'm gonna ask my colleagues to ask questions. On your EHR, or even just your IT healthcare, does GMH have a plan to attract and recruit IT healthcare professionals with specific skills set required for managing database employee? I mean, just your whole program. Do you have IT folks employed? Go ahead, say yes, put favor, and you're going to hire more.
Yes, we do, and we plan to hire more. The inventory of IT people, it's not a lot out there. Everybody's scrambling to hire IT professionals across the island.
Okay. While you're hiring, do you have a solution to privatize maybe even the IT department there? Maybe a public-private partnership, something where you can bring an IT agency in there and says, we'll take care of all of this. We'll keep your employees, public-private partnership. We'll get it running. And the reason why I bring up public-private partnership, because one of the beauties is you don't worry about procurement. When a private company gets involved, they need this item, they're going to buy it, and they buy it cheaper than the government can buy it. That's a known fact. If a private company comes in and become a public-private partnership, the price of goods is cheaper. When the government goes and buys, because of the time it takes for them to pay it, they could have sold that item 10 or 20 times. That's why businesses are never in a rush, and the prices are expensive. So I was just concerned about that. That being said, Madam Speaker, do you have any questions? And then we'll proceed with Senator Perez, and then Senator Blas, and Senator Canata. Thank you.
Thank you, Mr. Chair. Most of these slides on the CIPs are identical to January's oversight hearing that we had. And there is overlap, as you noted, Mr. Chair, between the mold mitigation chart, the capital improvement chart under the ARP, and the capital improvement projects in the pipeline, or going to be planned for 2024. I just wanted to talk about, so overall, right, we know that you had billing issues, so you weren't able to meet the revenue that you had projected for FY24. We came in with a $30 million appropriation above what we had already budgeted. That was for vendors that were past due. So you've pretty much caught up with those vendors, right? And even, we talked about this at the last hearing as well, you even paid with that money. One of the vendors is that the company that the public auditor has said now that he's questioning the costs for, right? Like in $4 million, or what was that amount?
4 million.
Yeah.
Overall.
All right. Is there any efforts to take back any of that money, or he said we paid for services that were not completed, or is there any efforts in regards to that contract?
No.
All right.
We did pay up to October only. They did invoice us for the November, but we did not pay that.
All right, and then we talked about the rebasing efforts for the Medicare. So we're stuck at 2014 rates. It was increased to 2016 at a certain point because of efforts that the CEO had made. with Medicare, and we've talked about this in our previous hearings, that we are supposed to be making those efforts as well to rebase Medicare. So you said that you are approaching consultants. Can you just be more specific? Where exactly are we on these rebasing efforts? Are there any formal efforts or not yet?
I was asked to provide the last 5 years of our Medicare cost reports to the consultant for them to review, and then they're going to come back to us with what the next steps would be.
So you've procured a consultant?
DOA did.
All right. To
And so we're
rebase GMH's Medicare?
I'm not really sure, but the
tell you the
beginning
next
steps
steps.
of it was to just at least provide the 5 years of the cost report to the consultant.
All right. And but GMH, as the chair said in the beginning, continues to request additional funds, or looks like it needs additional funds. One of the requests was for nurse pay, but we kind of resolved that with letters with the DOA saying that the remainder of the 30 million could be used to offset nurse pay if there's a new nursing pay plan that's adopted. Has there been one?
It's still in the discussion with DOA. We haven't gotten anything final yet from DOA, but there has been talks about it in terms of for LPNs and RNs for their salaries to be increased.
All right. And then the billings, Yuka, you're saying, are you hitting your $11 million goal for collections?
Not quite. Almost, but not quite. We're still doing a lot in the last 4 weeks or so with really ramping up the coding backlog that I discussed at our last hearing, that we had a big coding backlog. So in the last 4 weeks, we've put together a task force and added additional resources to the coding team. So now they're able to bring that down to, now we have, I think it's like 9 million uncoded from 26 million before. So they're able to bring it down with the additional resources we give them. Now we need to get those claims. We have been, as they code it, we get the claims out the door, but now there seems to be a backlog now on the billing side because they're just inundated with all these claims now. But we're also addressing that with giving them resources. So, and then of course after we bill, we don't get paid the next day. We have to wait at least 45 days maybe, and then the insurance companies will pay. Medicare pays very quickly. They pay within 10 days to 2 weeks, so theirs is a lot faster.
All right. And those coding people that you hired, are they permanent? Or those just
We
temporary?
actually have coders within GMH. They may not be in the coding department, but they have the skills to code from other departments. So we have a coder in our, 2 coders in our revenue integrity department. We have another coder in the radiology department. And then we're also training the staff in our utilization review department to code in case we do fall behind, so that they can also add assistance to help get caught up in the coding. So we were able to use our resources internally to catch up on the coding.
Okay. And then in addition to needing money perhaps for nurses or to increase the compensation for nurses, at the last, or one of our oversight hearings, there was testimony that GMH lacks regular essential materials like linens and pillows, diabetic tube feeding formula, underpads for patients, inner tracheostomy cannulas, wipes, pre-filled epinephrine syringes, and other items. Is GMH still lacking these items?
Depending on the vendor, and as you mentioned earlier, the 30 million was then to pay for those old invoices. But you know, you run the hospital, you're continuously incurring bills for the supplies. And so, you know, even though we paid those vendors for those old invoices, we are accruing also some invoices for like laundry, pharmaceutical items. And
Invoices,
so-
yes, but are you able to get the services and the supplies, or have the vendors stopped? I mean, are there any supplies that you were not able to resume because of our late payments?
We're very fortunate that some of the vendors, they are very understanding of our situation, and so they continue to provide us, but they do warn us that, you know, we may need to put you on credit hold. but we do get the supplies, depending on the pharmaceutical items and medical supplies that at the manufacturing level, they also are short of those medications and medical supplies, so
So
there's
from-
different factors.
All right, so from the list I read, you think you have those supplies?
From what I know, from our materials, we have those supplies, yes, ma'am.
All right. And so the other thing, in addition to the supplies and the nursing pay, was like specialists, right? There was discussion in the paper regarding the need for specialists, particularly for, I don't know if it's pediatrics or neonatal. And my concern was, we had talked about the 5 million that was appropriated by the legislature for specialists. I know you said some of that's being used for telemedicine, and then you gave us a list of the other specialists that you were trying to recruit. I think neonatal was one of them.
Yes, we are aggressively recruiting for neonatologists. One that medical staff, Dr. Duenas, is going to be interviewing via Zoom. You want to go ahead and speak on it, Doc?
The neonatology is a maternal health care in Guam has been in the newspaper, definitely, but we are trying to make some corrections. Initially, the maternal health care needed some help, and telemedicine was an option. And so we do have telemedicine in neonatology and pediatric PICU. But our physicians feel that they prefer boots on the ground, and we're on overdrive trying to recruit actively. And so right now we are going to be interviewing, I believe in 1 to 2 weeks, a neonatologist to see whether we can have her take a look at Guam as a place to come. Now, we have not made that interview yet, but I can tell you we're going to be very aggressive in that interview when it does occur. So at the present time, we're asking our pediatrics, anesthesia, and OB committees to take a look and look at the current state of where our maternal care is and where can we further improve it. Right now, we are using telemedicine, and we don't have boots on the ground for neonatology.
Is it correct that GMH is authorized by law to recruit medical professionals at pretty much the rates set by the board? So they don't need to follow DOA, but they can adjust if you need to hire a neonatologist, for example, right? All right, so that was one of the special powers given to GMH in order to recruit specialists. So my concern is that I don't know, I still get complaints about the above-step hiring of non-medical professionals at GMH. So, of course, this was several years ago. The first big one that came to the news was the hiring of a PIO above step at $160,000. Then there was the just recent couple above-step procurements of, looks like, Deputy Assistant of Operations, and then recently, I want to really ask you about this one. It's a hospital chief planner. I'm sorry, it's kind of awkward because I know some of these people are here, but I'm just going to have to do it. So, sorry, Mr. Kando, but Mr. Kando started as, well, when I met him, he was the hospital chief planner. That's step one position at $80,000. He became the Associate Administrator of Operations, which is $115,000. That's an unclassified job. Unclassified, appointed by who?
By the governor, because that is a cabinet level position.
Okay, so are all these unclassified appointed by the governor?
No, not necessarily, because we also hire above step for nurses, for professional services.
No, I mean, okay, I'm talking about the Associate Administrator of Operations, you're saying hired by the governor, cabinet position?
Correct.
On your staffing chart, these are, below the CEO. There's a Associate Administrator of Medical Services. Is that hired by the governor?
No. That is the Medical Executive Committee makes their recommendation and then gets hired by the administrator and the Board of Trustees, of
Right.
course with the concurrence of the governor.
Oh, okay, but that's unclassified as well?
That is
Concurrence of the
unclassified,
governor.
yes.
And then the chief financial officer, this is also appointed by who?
By the administrator.
All right, and the associate administrator of clinical services, this is appointed by who?
By, again, the administrator has the authority to hire the clinical services.
Okay, I couldn't find in the statute which ones were under the governor's appointment authority versus the CEO's appointment authority, so maybe you can just send those things to me to clarify. Thanks. So back to the, when Mr. Cando became Associate Administrator of Operations, 115,000, that's a unclassified position appointed by the governor, you said, cabinet level. Then I read in the paper there was a civil service appeal. It was explained to me when he moved to a position that was classified, maybe October 2023, Assistant Administrator of Operations. That's also on this chart. That's right below the position he was in, Associate Administrator. He went right below that to the Assistant Administrator, classified 95,000. There was a civil service appeal. My understanding is that because he had asked for above step, and that was denied.
Correct.
And that is still not settled with civil service, is that correct?
The hearing is pending this Friday
Okay.
from the audit of
So there's
the-
no decision yet, and my understanding is it was denied because he had already been working for the hospital, and there was a interpretation that he cannot be hired above step because he's already an employee of the hospital, and that's for recruitment of new hires.
That was according to the 1995 Civil Service Compensation Policy.
Okay.
So I was just following that.
All right. And then after that, January 2024, he was hired above step recruitment, hospital chief planner. Step 1 was 80,000. He was hired step 10, 109,000.
Not yet.
Not
That's
yet?
still going through the petition process, and so it's also going to go through the Board of Trustees. I've requested the Attorney General for his advice and guidance in terms of coming from a non-classified to a classified if the above step is applicable.
All right, but
So
at this
it hasn't
point,
happened.
he would be going from a classified to a classified.
Correct.
Okay. And so you're pending an AG opinion and you're pending a civil service as well.
Well, the civil service decision and ruling is going to be the one that he petitioned for the above step for the assistant administrator, which he currently holds right
Okay.
now.
All right. The reason why I'm bringing it up is like, I know why he's being recruited above step because he's been in this position for so long, has all the expertise. But it's just that, yeah, when we have, and I know you gave a report at the last oversight that said there were 8 above step recruitments of non-clinical positions, and then you said there were 41 above step for clinical positions. But I don't know, I'm just bringing that up because if we're trying to recruit specialists, I just want to make sure everybody's clear. It's not a money issue, because if it was a money issue, we would be taking care of this. We would not, I don't think, be recruiting above step in non-clinical positions if we really needed to hire those doctors and we needed money. Is that correct?
For the doctors, it's a separate process in terms of negotiating the salary.
Right. But the money, I'm saying, we should not be saying we can't hire these specialists because we don't have enough money. We've put out all the stops on that.
And those positions are budgeted for, so we use those funding.
Okay. And yes, and yet we're still having issues trying to hire them, right? To recruit them.
I mean, Guam is not all that.
The issue is not money, as you say, Senator.
That's what I wanted to say.
No one has not yet stepped up to come to Guam, and so that's what we're working with. So it's availability and accessibility. It's not a money issue right now. Now, until we start negotiating, then we may have to address that.
All right. That's what I wanted to make clear. Like, we have money at GMH, and there is authority at GMH to hire these medical professionals. Yes, GMH is choosing to hire some non-medical above step, several of them, in fact, and but supposedly, I guess we're supposed to imply that that's not affecting your ability to hire the medical professionals.
What's affecting it is people not wanting to come to Guam. So, you know, we try and
right.
court them and recruit them. Even we're going to be even using the off-island recruitment where we bring them on a
right.
airfare.
On the same day that we appropriated the 30 million for the vendors that were not paid because of the billing system that went offline, and when the hospital's electronic systems went offline, so we got behind. We were not able to pay our vendors. The legislature appropriated 30 million. On that same day, the governor issued an executive order setting up a fiscal review committee with a list of things that they were supposed to review and give recommendations to the governor. Some of it is expenditures over $1 million, all of this facilities, maintenance, the Medicaid, the Medicare, all of the things pretty much that we've talked about today. Has this committee come up with any recommendations as far as you know?
It's basically looking at our monthly expenses and how we can then try and make sure that we meet those financial obligations, but not so much solid recommendations. The only one was what you can mention was the 5-year cost report from Medicare cost report, so that then we can push and go forward with the rebasing from Medicare.
Okay, so yeah, but the EO says pretty much assess and make recommendations to the governor regarding the following, and then there were different lists, and one of them is even the 20 million, the allocation of the 20 million. I'm just concerned that this was since October 2023, and that 20 million has been laid out since October 2023 to today. I guess we're hearing that they're not all completed yet, obviously, but some of them haven't even begun, the 20 million.
Well, the commitment is there, and the money, the 20 million is there. It's just not in our hands. We have no control.
All right. Thank you, Mr. Chair. Thank you, Lily.
Thank you, Madam Speaker. Question, I made sure you got a copy of your chart. And as the Speaker brought up, certain positions there are governor appointed.
My position and the Associate Administrator of Operations is appointed by the governor, correct.
Okay, it just kind of bothers me. If you're the administrator now, you're in charge, right? No? And if anybody below you is also appointed by the governor, then it is, by granting act, she's in charge anyway. And I just can't, I'm going to take a look at that. I'll get my staff to take a look at it, because if somebody's appointed in charge of an agency, that's the person we're going to always look at, and your CFO or comptroller and everybody below you. Not say that you're in charge, appointed by the governor, but somebody below you is also appointed, you're almost equal. And that doesn't sit well with me.
Maybe I am mistaken about it, but that's how it was when I started in 2019.
Yeah, but I'm going to look at it, because I know that Doc knows where I'm coming from. In the military, you're algo magas. Everybody below is not magas no more. You may be in charge of different areas, but the guy on top or woman on top, you're in charge.
Well, but I have the governing body too, the BOT.
The statute, however, Mr. Chair, says that the board shall hire an administrator, its CEO, and the salary, duties, and compensation of the CEO shall be determined by the board. I was looking for the other one that you said is a cabinet position. I just can't find that one.
And that's why I bring that up. And I'll be looking into that. Simple question, and then I'll ask my colleagues, ask a question. Of everything you've discussed, all your financial status, other than the mold and everything else and equipment, Medicare, Medicaid is one of the financial that's bringing you down the hole. You build a new GMH, is that resolved? The answer probably is no. Am I correct? You can answer that straight up. If you build a new hospital, I don't care where it's at. You build a new hospital, does that go away? The reimbursement?
No, we have to address it. It's
Okay.
quite urgent, yeah.
We do understand that the public law, that it does exist to fund a new GMH or a medical complex, whatever they choose, but a new GMH has a caveat that when you're going to borrow, you got to make sure that the current hospital is operational and maintained until a new hospital is built. I mean, until you have the key to open there and walk in. So whatever conditions you're running into, and whatever direction we're going to go in building a new hospital, they need to help you. They need to get the hospital fixed and running. The idea, the concept of getting reimbursement from anywhere else, you guys figure that out. But everything else, you need to fix the ceiling, you need to change shutters, whatever, do it. Because why? At the end of the day, wherever they're going to build a new hospital, you can't borrow a penny following the public law that authorizes you to go to the bond market until you, only if you're maintain and get this current hospital running. Otherwise, it doesn't work. Because when the new hospital opens up, that building should be fully functional for whatever purpose the government is going to end up using it for. I just want to remind and make sure that the listening audience understand that. And with that, Senator Perez, do you have any questions you want to pose on the panel?
Sitos Masi, Mr. Chair. Lillian, where in the staff hierarchy is a chief planner? Because it's not listed, from what I could tell from the budget. Where would that be located?
In the organizational chart,
Yes,
the chief planner?
Yes.
It falls under the operations.
So is it below the Associate Administration of Operations or above?
Below.
Below, okay.
It's not showing in that organizational chart?
Not that I could tell.
Okay.
So is that a unclassed position?
It's a classified position.
Classified position.
Yes.
Okay, and so Mr. Kando, is this the position that you're applying for, the chief planner? Or
Applied for.
you applied for? Okay, and so I guess, considering that we're using a merit system, how is this possible that we can, has this position been opened up for others to apply?
Absolutely. We announced it. Yes. That's the competitive classified hiring process. We announced it, and Mr. Kando was the only candidate who applied, and he was interviewed and selected.
Okay, and so the salary is how much for that? Or is it an above-step recruitment for the chief planner?
That's what he's requesting, is above step.
And so with this salary request, would that put this position at a higher compensation than the position above it?
It's the pay range, the pay grade, I believe, is a pay grade R. And so the steps, I believe up to step 10 is about 109,000 per annum. I believe that's what that step 10 is.
Okay. And so this chief planner, can you maybe describe the procurement process of the hospital? So who has the ultimate final decision of how the procurement is done?
Okay, the procurement, in terms of an RFP, the RFP is then crafted by the servicing agency that needs it. And so like, for example, the EHR, we had IT begin the crafting of it, but then we also had others give their input, their comments, such as for the EHR, we have the clinicians, we have the nurses, and we have now the doctors looking at that draft RFP so that they can give their input as what they want this product to be, because they're the ones who are going to be using it. So what they want this EHR product to be. And so once we complete all of that, get all the input and the feedback, we will then finalize the RFP. Once we find the funding for it, then we certify that RFP and then publish it. And so we go through that process. That's the procurement of I guess, a product that we need. Same thing if it's a professional service that we need, we do an RFP. If we need for example, immigration counsel, a lawyer whose expertise is in immigration recruitment, we do an RFP for that. The recruiting, the department responsible for that will be HR and medical staff, because they want, and nursing. They want to give their input as far as how we see this immigration lawyer in terms of recruiting for health professionals, for nurses from the foreign countries. So it's a collaborative effort in terms of writing the RFP. For hiring, again, it's a competitive hiring. So HR initiates the servicing department. For example, Mr. Cando's position of health planner, it's the associate administrator of operations or the deputy assistant or the assistant that issues that GG1 request for HR to then process the job announcement. Does that make sense?
Yeah, so basically you look towards the department who is going to need those services.
Correct.
Or it's going to be integrated. Okay, so in regards to like capital improvement projects, who is the, I guess, who does the solicitation preparation, the bid package?
Whether it's an IFB or an RFQ,
Right.
an RFP.
Right.
Materials management works closely with FM, and, if it's a nursing, product that they need, such as a medical transport, they work with nursing to put the specifications for that.
So would that be Mr. Cando then? Would he have the, Mr. Cando, are you the person in charge of deciding what type of source selection it is?
Of course, each IFB or RFP would have an evaluation panel that the hospital administrator, as the chief procurement officer, would select an evaluation panel to then make a recommendation on who is the lowest responsible, or who is the best offer for an RFP, or lowest for an RFQ. Those recommendations are then channeled to the chief procurement officer, who is the hospital administrator.
Okay, so Lillian is the one that you're the determining factor as far as what type of procurement?
As far as the type of procurement, it depends on if it's construction services, if it's professional services like an A&E. It's understood that professional services would be an RFP. If it's construction services with very finite scope, with a set of designs and a scope of work, we know that's going to be an IFB. Potentially, some of these could be an RFQ. So, we work very closely with materials management. Whoever the initiating department is, of course, planning and FM are usually involved, and of course, we have that discussion, with Lillian as the chief procurement officer, especially if something has to be given advance notification to the AG's office. Depending on the amount of this RFP or IFB, we would have to, of course, the AG's office would also be involved before we advertise.
Okay, so Lillian, so who is your go-to group as far as deciding what the source selection is for the hospital?
Materials management really is our procurement expert people that I rely on, but working again alongside with the operations.
So who's in materials management? Who's in that group?
Lola Pangilinan, Dolores, we call her Lola. She is the materials management manager, and she has her team. But she works, again, collaboratively with the various departments. If it's a pharmaceutical item that we need to procure, she works then with pharmacy. If it's a respiratory, a ventilator equipment that we need to procure, she works with the respiratory department. If it's a radiological equipment that we need to procure, she works then with the radiology department.
Okay, and she falls under Mr. Cando?
Correct, she falls under operations.
Mr. Cando, then you have in the hierarchy, then you have a greater say in the procurement process, is that correct? Because you oversee the materials management position.
Yes, I have responsibilities that I need to fulfill.
So then, would you say that ultimately that's your responsibility as the procurement, the one who decides the procurement solicitation or the type of solicitation that's being
No, I would say that it's pretty much a team effort, especially if we have legal questions. We even confer with our legal counsel.
But you're in charge, so you have to make that decision, deciding. You're the one who has to decide if there's a question. Is that correct?
I make recommendations. At my level, I make recommendations.
So you're saying you're not the deciding person at this point? You don't have responsibility? Is that what you're
I
saying?
have responsibilities and I make recommendations. Sometimes they're followed, sometimes they're not.
Okay, in what cases were they not followed?
When I was wrong.
And specifically, what type of procurement?
I don't have a particular example. I mean, I've been doing this for so many years. I mean, so, you know, I do my best and I make recommendations, and that's why procurement is so complex. It really is a team effort.
So who signs off on the procurement?
Who signs off on the procurement?
I have the legal responsibility to sign off on those procurement.
Okay, and then who's a certifying officer?
That's me.
So do you sign off that procurement document as well?
No, I sign contracts if they need to be certified for funds, if there's a contract involved, and the requisitions at the onset of the procurement.
Okay, is that an issue? Because, you know, this chief financial officer, I mean, how does that work? Because if you don't have funds for something, how can you procure something?
Then we don't.
Can you explain?
So if a requisition comes through, say for example, FM needs a large expensive piece of equipment, and this happens a lot, but we just don't have the funding for it. It goes through our budget office, and if we can't find funding for it, I don't sign it certified. So I hold those requisitions, or we kick them back to the department that there's no funding right now, and they're going to need to look for funding. I always encourage, you know, them to look for a grant or something if we're in that area where it might be possible that there's grant funding, and sometimes we can find grant funding. Sometimes we have to go ask other areas if they have money, but I won't certify it if there's no funding.
Okay. So you're the only certifying officer in GMH, is that correct, Yuka?
It's me and also the general accounting supervisor. She is my, if I'm not here, then she will be the one to certify.
Okay. So I know you said earlier that you're trying to, basically there's a $30 million gap in regards to expenditures, and you know, I think procurement is one of those ways that you can close those gaps. And so, you know, I think that, you know, when I'm, you know, the responses that I'm getting are not quite comforting to hear that there really isn't, it seems like there could be some improvement when it comes to maybe finding better value in what's being purchased, and that can come down to the source selection itself. Yes.
So if I may kind of respond to that, or just to clarify. So of course, I've just recently started with the hospital, but in my role, the procurement, like the solicitation, those things, the requisition, or actually the purchase orders do come through our desk. And so when I review them, I do take a look. And so the hospital is making better efforts as far as trying to review, again, like you mentioned, the source selection, making sure, are we following procurement rules and regulations? Not that we're saying we've never done it, but, you know, we're taking a closer look at that. Even as far as some of the procurement, asking the questions like, does it make sense? You know, why are we procuring this? Why not this? You know, so asking the questions. And it's not really that anyone's doing anything wrong. It's just clarifying, just making sure, okay, everyone's aware. Are we all on the same page? Is this really the item that we need to get? Is it, you know, are we ensuring that whatever we put in the specification, is that really what the quotes or the bids that we're getting, is it in line with what we were actually asking for? If that makes sense. So we are going through that. We are trying to do some cost cutting. So not only on the fiscal side, even on the operations, we're working with the teams to kind of relook at some of our processes to make some improvements.
Okay. Yeah, and I think that's the Fiscal Review Committee. I mean, I wish that could provide more assistance. You know, they do have a new acting CPO, as well as, you know, Director Byrne. I think he has some, perhaps some review. He can help with reviewing some of the procurement as well to ensure that, you know, you're getting the best value. So, I definitely want to encourage you to. Yeah, I think there seems to be from what I'm hearing, there's an over-reliance on the RFQs, which come at a premium price versus the IFBs. And so I'm just kind of concerned about this rush to use RFQs and what it can cost the hospital, and whether, these are areas where we can find, potential savings. Okay, thank you. Thank you, Mr.
Okay, thank
Chair.
you. Senator Blanche, do you have any questions for the panel?
Thank you, Mr. Chair. Before I get into the questions, I want to thank you, Mr. Chair, for recognizing that we need to fix problems before we build new ones. Okay. And then some of the questions here is just a regurgitation of what you had probably presented, Yuka, in your presentation, okay? You basically, first off, you said you had a projected shortfall of about $30 to $60 million, so that's what you're anticipating? Or it should have been 60, but it's going to be down to 30?
Yes, sir.
Okay. What has been your average shortfall for the last 10 years?
In the last, I'll say, 4 years since the pandemic, it's been between 60 to 80 million. And then prior to that, it's been around 20 to 30 million.
Okay. So 20 to 30, 60, 80. Let's give it the medium of about 50 or about $45 million annually for the last 10 years. That's $450 million. What's your total operating budget annually?
About 190.
190. So right now your shortfall is about 3 times what your annual operating budget is. Right?
The shortfall, can you repeat that?
Your shortfall,
The 30
if you were
million.
to cumulative for the last 4 years,
Oh, I see.
okay, is about basically 3 times, almost 3 times your annual
Yes.
budget, right? So your total operating cost is what, 190 million?
Yes, currently.
What's your annual gross payroll?
120 million. It's 4.2 every pay period.
4.2 every pay period? So 120, about 120 million annually?
Yes.
So that leaves you 190 minus 120, that's $70 million to $60 million. That leaves you $10 million to get pharmaceuticals and supplies and whatnot.
Yes.
Right? I'm just doing DI math.
Just, yeah.
Okay. What's your accounts payable right now? I know
It
you've-
is 16.
Huh?
16 million.
16 million? What about your accounts receivables? How much do you?
I have 2 answers for that. So
Okay.
we have the gross amount, but we also have our, the net.
Sure. What
So
is it?
in the slide presentation,
I know.
it was almost like 50 million on the receivable side.
So how much on the gross?
42 million.
For what? How much on the gross?
Receivables.
Yeah. You said you have two figures, one gross,
Well,
one net.
yeah, the gross is, of course, a lot higher. It's 362 million.
And then your net?
42.
42. That's about $320 million delta between the two. So we have $320 million that we can't collect. We have $10 million left over in what we are collecting after we take care of payroll and everything else. How do we fix that? You know, I sit here and I listen to a lot of and then you've got anywhere between a 40 to $60 million shortfall, and you continue to have that. See why I'm getting into this, let's fix our problems first before we move into another building? Because I haven't asked you, and I will ask you now about now some of your current problems that have added to your costs. Your traveling nurses. How much did you say that you owe right now, traveling nurses? Let me add on a quick question. How much do you owe DOA for your traveling nurses? Did I hear that correctly?
$4.7 million.
$4.7 million. Is that something that could have been paid off with utilizing another funding source that's available to the government of Guam that we don't have any ability to touch? In other words, isn't that something that we can pay off? It can be paid off by ARP?
I suppose.
I know you can't answer that, but I'll just tell you, there's something that can be paid off using ARP instead of asking you to pay $4.2 million, which you need to continue because also a lot of the stuff as was you testified to earlier, you want to be able to get stuff, but you can't afford it. Well, guess where there's $4.2 million. Your social cases. I know we had this discussion a couple of weeks ago when we met. And I know you gave me some hard numbers with regards to how many social cases you have. And Lillian, thank you. So just to clarify, for the purposes of this hearing, your social cases are defined as those individuals or those cases, patients, if you will, that have already received the adequate and sufficient health care, hospital care, but you can't release them because they have nowhere to go. And you have some of these cases that have been there for a year, over a year. Has anybody calculated what your costs are? How much does your social cases cost?
For the 12 cases that are in the hospital, acute, it's about $9 million. And the ones over at SNF, $4 million, 4-point-something million. Yeah, so total is really $14 million.
14 million.
From the time that they were admitted in 2021 to present.
There's 14 million there, 4.7 for the nurses. Okay. We found already what? Okay, about $18 million. Is it getting closer so you can get your supplies? Has there been any discussion as to what we're going to be doing with these cases, these social cases? Because you obviously, I'm sorry, but you can't continue to do that. I mean, as much as you're required to do that and you don't want to just throw them out on the streets, you're using resources both financially and personnel-wise, and bed space, mind you, okay, to be able to continue to provide this. Has there been any discussion with your sister agencies that should, so what has been the discussion there on this?
We do have a transitional care task force that is with public health, behavioral health, and DISIT and GMH. And so we're discussing, we were supposed to meet last week, unfortunately it got rescheduled. We're meeting, I believe, this week to then discuss further what our options are to place these individuals in a home setting. The other option that we're exploring is it's called a family, some kind of an incentive program that Medicaid in other states offer compensation to family members to take care of their ill members in the home setting. So they are incentivized by payment. So rather than keeping them in the hospital, we send them home, pay the family member or somebody, a caretaker, to take care of these individuals in a home setting. So we're exploring that too.
So in comparison, and I'm sure you've done some little bit of research on this, Lillian, what's your cost per patient per day in these social cases?
Per day, we haven't calculated that, but we can certainly calculate that.
Yeah, because I'd be very much interested. What's your cost per patient per day in your setting and the cost per patient per day in that setting. Okay? And I'm sure we're going to look at a market difference.
Yeah, we can take a look at that.
Reduction.
Right,
On this
because
thing,
in
it's not, okay?
In the ICU level of care, the cost per day is about 10,700. But these individuals are not ICU, but yeah, in the ICU level, it's about $10,774 per day.
So along those lines, what's your average cost for your patients in SNU or SNF?
It's a lower rate.
Just specifically for SNF,
Yeah,
I have the overall for the
just give me
hospital.
your best guess estimate.
The room rate now is about $1,000 per day. Medicaid reimburses us about $320 a day for SNF patients.
So there's a huge disparity already, and really, how do you justify with Medicaid for a social case patient? You're not necessarily giving them medical care, but you can't set them out, and you have to give them some type of care. So is there a problem as far as the reimbursability of just providing that service?
Absolutely, yes.
Okay, wow. And these are problems that we don't want to take on to a new facility. See what I'm getting at, guys? Okay. Again, I appreciate all the efforts that you're doing to try to be able to do this, but it exists. Let me get into now the mode issue here. And we had the discussion, Doc, I remember us specifically having the discussion a couple weeks on this thing. And there has been has there been any reports from staff or patients of respiratory ailments or complaints?
Senator, our infection control division has looked at that, and we have no documented laboratory documentation that residents or patients or staff have been infected by moles.
Okay, so the question, so you have no documented laboratory tests. It bothered me when we were having this discussion after we were done, because then in order to get a laboratory test, it had to be reported, and then the laboratory tests had to be provided. Okay, and so you may not have the test because it wasn't reported to you as such, and therefore you didn't order a test. Could that be the case?
Usually the physicians make a provisional diagnosis. If their provisional diagnosis is moles considered, a test will be done.
Okay, but there hasn't been, and there hasn't, so, it's not to say that the physicians aren't doing their job, or in some cases, staff and patients just don't complain about it.
Yeah. Well, when someone comes to GMH with upper respiratory infection, it could be from COVID, from virus, a whole bunch of other stuff. And so we know what's in the community, at least, and we do know that viral infection is very high right now, not necessarily COVID, but so if the physicians will make their diagnosis, this is probably an upper respiratory infection, more often to the more common causes, which are virus and not necessarily mole. And they probably will not, we will order viral testing, COVID testing, but we do not order automatically mole testing.
Okay, yeah. And I understand why, because I understand why. Thanks for that. I'm just concerned because it just bothered me when we had the discussion about maybe there was something missing as far as the discussion, a question that I should have asked, and I was asking, that's why I'm asking now, okay? But then also, another thing that brought to my attention, the reason why I was very much concerned about this, and Lillian, we had this discussion several months ago about my concern with the number of RSV cases that have been reported. Okay? Now, I know that it's, water under the bridge, can't go back to it and everything, but I just wonder, is it a possibility that an RSV case can be related to a mold infection?
We have no information on that.
But can there be a correlation to to the two.
And we're talking about mole plus virus. Now,
Right.
you could have concurrent disease, virus plus mole, but we're looking at the more common cause, and it's going to be a virus. So we do have a viral panel testing, and we do, physicians do order that.
Okay.
We check for RSV, we check for other viral, there's a panel, and we check for other viral causes.
Okay.
But
Okay.
that panel does not include mole.
Okay. So, but I noticed that in your mitigative efforts, there's going to be increased surveillance too with regard to any suspected mold infestation or within patients and staff primarily, okay? Right? Now, let me okay. Last area of concern that I have. Your EHR, all right? You know, I know we had the discussion and apparently it wasn't suitable for acute care setting. Is that the case, right? Who recommended that system?
Okay. Historically, with the old EHR, that was the Optimum, that is a Cantata product. When Cantata notified us that they were going to be sunsetting that Optimum care EHR, they recommended that we go with MedSphere Company because they're affiliated, and so because they're affiliated. MedSphere.
Okay,
MedSphere. Yes, this CareView EHR product is a product of MedSphere. That's the vendor that we work with now. And so when they were sunsetting the Optimum, they recommended that we switch over to the MedSphere CareView. And because they're affiliated, we didn't have to go through the RFP process. We went through the novation process.
Novation process.
Novation, correct.
Okay. Who's the representative on Guam? Who's the representative on Guam for you? Who do you call on Saturday morning at 3 a.m.? Should something
Regarding
happen?
the MedSphere or
Yeah.
the CareView? We do have our IT people, and so then they also connect their calls to the support tech that is off-island with MedSphere or with Cantata.
Okay, so, but there's no local rep on Guam? There's nobody that
Not from the company
that you can pull out of
themselves.
bed at 3 o'clock in the morning, have them fly down from Talofa or something?
Our people, our IT call them at the national level.
Prior to doing this, was there any discussion with the physicians or with the medical staff as to whether or not this is a good transition or something?
We've had discussions and we've had meetings that we have to switch because Optimum was sunsetting. And we've had physicians in a champion working with our team. Unfortunately, that physician left us.
Okay.
But we've had physician involvement.
What was the transitionary period between the time you needed to get out of that Optimum program and get into this new MedSphere program? How much time did Optimum give you to say, look, guys, we're not going to be servicing you or doing this anymore. You need to get out now, or you need to get out within time?
About a year that Cantata told us that they were sunsetting.
Okay. I'm sorry, Lillian, but when you got something as very concerning as a program now that didn't fit the acute care system, okay, and we had a year to be able to do, to tinker with the system, bang it a little here and there, check the nuts and bolts and whatnot. Why didn't we see then that it wasn't a system that was conducive to what we needed in our hospital setting?
Because they came to us with a team of clinical experts.
Oh.
That's what they said.
Oh.
They have a team of clinical expert people who are pharmacists, people who are respiratory therapists.
PhDs?
They come in, I don't know if they're PhDs, but they work in the clinical. They have that experience.
I found out that in some cases, PhDs actually stand for Pura Hodinagi.
A what?
Pura Hodinagi.
Okay.
Not to all of them, but
Well, that's what they
Okay.
told. They came to us with a team.
So they
of
basically
experts.
came and they, with their horse-drawn buggy and is selling the concoctions and whatnot, and so
And then the actual implementation got delayed twice during COVID, because the staff, the clinicians had to, focus on the patients. They didn't have time to be, focused on implementation of a new EHR.
Okay. Several months ago, I had put out a request, and thank you, you did respond as best you could with regards to emergency management, okay? And continuity of government and continuity of operations, okay? And I got back basically some language that basically says, because of what we do, we basically can't provide you information that you're asking for I guess for security reasons. I'm not going to ask you to tell me where you're going to go, but should something happen to the Guam Memorial Hospital and it requires you to move your services, do we have that facility or do we have that capability of doing that?
Currently, the SNF is what we call our alternate care facility, but it's not big enough. If we have right now 159 patients, there's no space at the SNF facility. So most likely, we're going to need to work with the doctors if any of those patients can be discharged home. And also, the SNF does not have the maternal child health capability. We can't do deliveries there. It's just not built for delivering babies. So really, we don't have any other choice to where we can bring these patients to, unless we collaborate and go and have GRMC will work with us to allow patients to go there, or if Naval Hospital will open their gates to allow patients, but there's no other facility on island that we can use as a go-to
Especially
hospital.
over the next 10 years, right?
Well, that's why we need to build a new hospital.
But over the next 10 years, we're going to need something to, right? Okay. I'm not arguing the point about having to build a new hospital. My point is making sure that this hospital that we need to rely on over the next 10 years continues to operate. Okay? And that's what I appreciate about what you're doing, you're trying to do. All right? Thank you. Thank you very much, Mr. Chair.
Thank you, Senator Bloss. Senator Canata.
No questions, Mr. Chair. Thank you for your guys' time and being present here today. Really appreciate it. Have a great day.
Thank you, Senator Q. I just have a simple question. Senator Bloss brought it up, and I brought it up earlier. How much money do you need today that can kind of like wash some of your problems away? Because the Medicare, you can't do nothing. You're going to deal with that every year, okay? Kind of like settle the things so that GMH can be up and running. Could you say 30 million, 40 million, done? Because whatever money else, whatever amount of money you got today, that means everything can be fixed. And at least, like Senator Bloss brought up, for the next 10 years, you just have to figure out the Medicare and stuff like that, but everything else will just fix it. Everything will be ready to go. It'll last for I know it'll last more than 10 years. Once you fix that air con and all that roofing, that's done. That building ain't going anywhere. Don't build no 3 or 4 story parking lot. We're good. But how much would you say? 30 million?
For today, yeah, 30 million will get us through this year.
No. Not this year. Remember, if I look at your report, you identified a bunch of stuff. I'm not going to talk about what you need to go back and recover, that 300 million. No, I'm just talking about what you need to fix today that should last you for the next 10 years. Because remember, the biggest push right now is to build a new hospital. So let's face reality. If they're going to build it regardless of where, and if they're going to use the public law that I introduced, that I got the body here to support, in order for them to borrow, they need to be able to maintain GMH. And in order for them to maintain, they need to do, one of those quick fix. Dump money, fix this and be done with it, because why? You're not going to replace aircon every month. You're not going to do it every other year. I'm hoping that whatever you're doing on air conditioning, you have a warranty of at least 5 years. Okay, you do the best thing, just do what you need to do is right. And I'm estimating that what I'm looking at is only it's less than $50 million you guys need. I'm not talking about what you need to receive from insurance or Medicare. I'm not talking about that. What do you need to fix? Because if you have a broken down building, it doesn't matter. Until you fix that building, it ain't nothing going to help you. And that's what I'm looking at. And exactly what Senator Bloss brought up. Need to get it fixed because he says 10 years. I say a hospital should be built in 7, maybe even 5. But how much would you need, Yoko?
We have the 5-year CIP plan that from 2020.
How much?
3?
How much, Ambi?
That was a big number.
Don't tell me 100 million because I know you don't need no 100 million. If that's the case, you need to tear down a lot of parts of GMH. Really?
Yeah, for the 5-year CIP plan, 5 years, we're looking at about 150 to 160 million.
To do what?
That includes a new EHR that could potentially cost anywhere from 20 to 60
The
million.
EHR, you're going to figure this out because that's what they call self-inflicted, okay? You figure that out. I'm talking about everything else.
Other things such as like the main panel and sub-panels, a true hospital-wide build-out of the IT network, these we put in for
Be careful.
grants, federal
be careful
grants.
what you say because you gave me a report and it's on the slide.
Yes.
Be very careful.
So
I'd rather you come back before you start telling me 150 million. EHR, it's on you. You work with what you need to work with and you figure it out and you move on, right?
Well, that's what we're trying to do with other projects too. We're not trying to put it on the people of Guam. We're trying to put it on the federal government, like the main panel and sub-panels.
So you don't need
We put
100. You won't need 150 million. You
Well-
need a lot less because if you get the grants, William, you know it fixes it.
If we get the grants.
No. I'm very positive. I work with my OB guy who used to be the BBMR guy, and he reflects that every year, GovGuam pretty much misses out over close to $100 million worth of grants. And it's shame on us. The opportunity is there.
Well, on
It's
some
about
of those,
going
we're
after it.
actively working with Homeland Security, so we should know very soon if they're going to come through, these FEMA 404 hazard mitigation grants, which we're...
What I'm trying to get at, if you said today, could estimate the 30 to 40 million, which Senator Blas and I always seem to, we speak on the same wavelength on this. There's ARP money out there. There's maybe other sources of money. If they dumped it in there to you right now, you're done, you're fixed. For the next 5 years, you should be decently okay, maybe up to 10 years, but with good maintenance, fixing the Medicaid and all that stuff. Find another place to put the patients that need to move out so they'll be ready for other patients. It kind of fixes itself. That's what I'm getting at. You're going to throw me 150 million? You better go back and do your homework. But I'm telling you right now, I know it's not going to cost no 150 million. You don't need to be where you're at. You could rent GRMC for 150 million if that's what it's going to take. And Lillian's shaking her head like, dangerous, scary. But anything is possible. Anything is possible. You get a contractor here and you give him up to $150 million, he'll build you a new hospital wherever you want it. It may not be the full length, but they'll build you something. Go back, be ready to give us an update from this oversight hearing, and with that, we're going to close this up, okay? Again, I would like to first, there being no one else, to present anything or any of my colleagues to ask any more questions, I want to thank everyone for attending this oversight hearing and for providing feedback and suggestion. The oversight hearing is now adjourned. The time now is 4:37. We're doing good. Thank you, Lillian, and the
Thank you,
panel.
Chair.
Please, thank you for being here.
Thank you.
Dr. Duenas, thank you for being here, sir.